In this module, I want to give you an introduction to monolithic restorations and also talk about the new ADA spec for these all ceramic restorations. So the ISO and the ADA have come up with something that's a really logical way of thinking about these all ceramic restorations. And so the monolithic restorations, I like to call it the monolithic revolution, and it actually started on August 17th, 2010. Now, we didn't realize this had happened until early to mid-October when we realized this had happened. But then we went back and looked, and this is the actual date, August 17th, 2010, which probably will mean nothing to anybody anywhere. Maybe 50 years from now, we'll look back at it. But it was the first day that dentists prescribed more monolithic all-ceramic restorations from the lab than they did PFMs. And so you can see the PFMs is that blue line kind of going down on the graph over time. And the green line is the monolithic all ceramic. So this is the combination of lithium disilicate, IPS Emax. And at the time, the only zirconia was Bruxer solid zirconia, the full strength one. So those two combined together as these monolithic all ceramics being prescribed more and more by dentists. And on that day in August, they outpaced the PFM. And you can see those lines just getting farther and farther apart. And that's back 6 years ago, 7 years ago at this point. So they're way apart from each other now. But we call it the monolithic revolution because it was the day where really nothing having to do with advertising or anything else. It was just dentists and their prescriptions and what they were asking for. And so it was kind of fascinating to see. And so dentists want to know, well, when you see a shift happen this quickly, when you take something like PFM that's 30, 40 years, been the number one choice of most dentists, and dentists start going to this other restoration. Is this a mistake? You know, a big signpost in terms of clinical success is that 5-year point. How are the materials performing at 5 years? But that's a long time to wait, you know, when you're trying to make recommendations to dentists about whether or not to use this. So I like to share these numbers. So these are the fracture rates within 1 year. And this is a really important number in the laboratory because you want to get an early feel for whether or not something is successful in the hands of your dentist. So in a research paper, 5 years of clinical success is certainly important. And it's a landmark, something that every material wants to have good numbers when they get to that 5-year mark. But in the laboratory, we've had materials fail before, and you need to know when to pump the brakes, when to pull the ripcord, and to start letting dentists know, we're having issues here. You might want to stop doing this. So really looking how the materials perform at 1 year is very helpful. So we can see if we look at anterior and posterior single unit crowns, the different materials. The lowest one, of course, is full cast, although nobody's doing full cast crowns. But it's at 0% because full cast gold doesn't fracture, does it? That's the great thing. You can chew a hole through it. We see patients do that who have had a crown in their mouth for 40, 50 years. But even then, you chew a hole through it and you just see the tooth structure underneath it. And the patient's like, what's that? You know, that's your tooth. You've eaten the gold, you know, over the last 30 years. Very slowly, but you did eat and swallow it. The amazing thing is you look at original Bruxer. It's the only other material for the longest time that we saw come anywhere near zero at 0.6%. Bruxer is static. You know, it's being done mainly in the anterior. We saw a few people doing it in the posterior. So that's mainly an anterior restoration, and that's why it's 0.7. You can see PFMs at 0.7% as well. And that number's you got to take with a big grain of salt, you know, because these are fractures on a PFM that are so bad that the dentist is cutting it off and sending it back to the laboratory and saying, I need to have a new one made. This one failed. What we know about PFMs from our clinical experience is that they chip and we can polish it off. There's a lot of times where something happens to a PFM, certainly in the past, and we would go in and kind of smooth it off, or maybe go in and try to use some hydrofluoric acid and some silane to put a composite patch on it if it happened to be a big bridge we didn't want to take off. So there's a lot of, you know, chipping and fracturing of the feldspathic porcelain on PFMs. That's not necessarily reported to the laboratory because it takes a full fracture and it being sent back to the lab for a remake. So it's got to be a catastrophic failure of porcelain in the anterior or the posterior for that matter. But the metal substructure never breaks. But we know there's a lot of chipping. that's going on. So that number is kind of artificially low because there's a lot more times where there are chipping and we don't know about it. Emax at 1.1%, which is pretty darn good for a material that I've already said should be adhesively bonded when it's put in the posterior to increase the fracture toughness. So when you look at these materials, it's kind of a golden age of restorations of like, wow, we have really good choices everywhere. I mean, cast gold's always been a really good choice, but patients don't necessarily like how it looks. When we look at bridges, full cast still the leader in the clubhouse at 0.0. 0.0. Email me with that movie reference and I'll give you a free reverse preparation burr kit if you know what movie that's from. We look at original Bruxer, anterior and posterior bridges, 2.1% fracture rate. I can tell you that those are all in the posterior. And that's a really high fracture rate considering if you look over at the single unit crowns that it's 0.6%. If I was good at math, I would tell you that's 300% higher or whatever it is, but it is a lot higher. And we see those fractures at 2%, PFM at 2.5% for bridges, just more stress on it, more units involved, so more chances of that feldspathic ceramic chipping or breaking off the bridge and needing to be redone. Bruxer aesthetic, 2.9%. Again, some dentists are wanting to use this in the posterior, but I think of it just as an anterior material. You know, the original name for Bruxer aesthetic was Bruxer anterior. I fought hard for that name because I wanted to tell dentists where to use it. But of course, when I'd be out lecturing and I'd mention Bruxer anterior and then ask if there's any questions, the dentist would always raise his hand and say, can I use Bruxer anterior in the posterior? And I'd be, oh, so much for naming it to indicate where it's supposed to go. And then with Emax, the fracture rate, 3.3%. Those are only anterior bridges. Emax is contraindicated as a bridge material in the posterior, any farther distal than, say, the first bicuspid. And so those are in the anterior. And you might kind of expect that would happen as well, although it's a gorgeous bridge, and if you prep enough and adhesively bonded, they work very, very well. So here's that classification that I mentioned a little earlier, this ISO 80A standard. And they've broken all ceramic materials into just 5 classes, classes 1 through 5. And we'll start with class 1, that's the weakest material, and they just refer to these as porcelains. And this is typically, when a dentist has said porcelain, this is what we're talking about. So it's got a flexural strength of under 100 megapascals, and the same kind of fracture toughness, it's under 1. And example brands of these are any feldspathic porcelain you can think of, like Vita Mark II or any ones from the old days. And they have to be adhesively bonded because they're pretty weak. But this is essentially the veneering ceramics that we think about anytime you're thinking of porcelain fused to metal, porcelain fused to zirconia, porcelain fused to alumina, whatever it might be. A step above that is the class 2s, the lucite reinforced glass ceramics. These are greater than 100 megapascals of flexural strength, typically around 115, 120. An example brand, it says Ceramco, but that's the better one is IPS Empress. I don't think they wanted to put two Ivoclar products right next to each other, so they put Ceramco. And these can be single units, anterior or posterior, although if you're doing it posterior, it's got to be adhesively cemented. If you're doing the anterior, it's got to be adhesively cemented as well. So these class 2s always need to be adhesively cemented. There is no choice. You cannot cement them with the conventional crown and bridge cement, which you can for the next step up, the class 3. These are the lithium disilicate materials, have a flexural strength higher than 300 megapascals. And of course, the biggest example of this, IPS Emax, as it says for indications for single units or 3-unit anterior bridges. And that's right. You can, so anything at class 3, 300 megapascals of flexural strength and above can be conventionally cemented. And the restoration will not crack because resin-modified glass ionomers expand for at least 90 days once they get into the mouth. As they sorb moisture, water from the saliva, they continue to expand. So under a strong restoration, like the class 3, 4, 5s or a PFM or cast gold, it doesn't matter. Resin-modified glass ionomers are fine, but the weaker ones, the class 1s and 2s, if you try to cement those with a resin-modified glass ionomer, 3 months later, it breaks because the cement continues to expand. But like we've said with Emax, if you're using on a molars, you're going to want to adhesively bond it so you can up that fracture toughness from 2. So it's at 2.0 as a material. You can bring that number up 30-ish% by adhesively bonding that crown, especially in the posterior if you're going to do that on a molar. The next class is the class 4, the cubic containing zirconias. So these are the ones that are the translucent or the high translucent zirconias. They've got a flexural strength higher than 500 megapascals. Lava aesthetic is an example, or Bruxer aesthetic. Most of these have aesthetic or translucent in the name to kind of tip you to this. Indications are for 3 units, bridges, anterior or posterior. Again, I recommend against using these in the posterior for bridges. I'm fine with them in the anterior for bridges. And but we'll talk about that more in a minute, because even this next step up, the strongest of all the all ceramics, the class 5 tetragonal zirconias, greater than 800 megapascals, usually closer to 1,000 or 1,100 megapascals of flexural strength. And an example is the original Bruxer, 4 or more units, anterior or posterior. Again, I don't even always love this full strength class 5 zirconia as a posterior bridge, and we will talk about that in a later module, why there are certain conditions where I still want to use a PFM bridge. But this is a great way to break up all these materials and be able to look at them and refer to them in a way when we're trying to decide what kind of strength we need and when we should be using these materials. So I really like what the ISO and the ADA have done here by breaking these up. And so we're going to use some other ways to talk about these materials too, talk about them as 3Y, 4Y, 5Y, but we'll also use this class 4 and class 5 designation when we're referring to these materials, or the class 3 materials. Most of what dentists are prescribing today fall into the class 3, 4, and 5 materials. You don't see, because even if we're doing veneers, most of the time it's IPS Emax that's being prescribed, which is a class 3 material. Obviously, it's a completely non-retentive prep, so we have to adhesively bond those veneers into place. But the class 3, 4, and 5 is really dominating everything now. The class 1s are just the layering ceramic on some of these restorations. And the class 2s, you find some dentists who are still using Empress instead of Emax in certain situations. But because Emax class 3 has 3 times the flexural strength of the class 2, Emax has largely replaced Empress as the veneer material choice for just about all dentists, including myself, because you don't see the chips on the incisal ledge that you sometimes used to with the class 2 materials. All right, so in the next module, we're going to go deeper into zirconia oxide and take a look at this. So this is going to be the class 4 and the class 5 materials that we see here, and go into the science of the material and all the special properties that allow it to behave and have these flexural strengths that are so high. Again, for the class 4 cubic containing zirconias, it says it's got to be a minimum of 500 megapascals. Most of the materials in this area are somewhere from 650 to 850 megapascals. And again, the class 5 is a minimum of 800. They're closer to 1,000 and 1,100. So really flexural strengths that we've never seen before for all ceramic materials in dentistry. And in this next module, we'll take a deeper look at why that is.